Welcome to this episode of the series Conversations in Medical Education, where we talk about some of the more difficult or complicated issues in medical education. I'm joined today by Richard Matthews, who's a philosopher of social justice and has a background in clinical ethics, particularly in First Nations health in Canada. And is a leader here at Bond in the importance of advocating for and delivering teaching around the social determinants of health in our program. Welcome, Richard.
Thank you.
All right, well, I wanted to start by finding out from you, how did you get interested in this topic of teaching the context in which patients live and teach and live and receive their healthcare?
Yeah, I mean, that's an interesting question. Sort of if you look at the history of healthcare ethics, it's actually acontextual, bizarrely. It has what you could call liberal assumptions sort of underpinning all of it, and so it's very much doctor-patient relationship, patient rights, patient autonomy, sort of very, very individualistic in its orientation. And the problem is that, while of course I don't want to dispute the importance of all those things, they are important. I actually think they're meaningless if you don't actually think about the context of the lives that people live. And so, for instance, we can talk all we want about informed consent, very, very important concept, but it's actually functionally meaningless if your experience of the healthcare system is racist, or LGBTQI phobic, or a misogynist, because what happens there is, if you're lucky, you'll get the form of the informed consent process, but you won't get the spirit of it. And in many cases, you won't even get the form of it. You'll just be, sort of run roughshod over in various ways, sort of by people within the healthcare system. And so, sort of this ties into questions of violence, which sort of really, really preoccupy me, sort of in the way in which sort of the healthcare system actually can be a system of violence, is a system of violence for marginalized populations. And so if we don't understand that actually the healthcare system is a highly ambiguous system from the standpoint of, the violence, that underpins it, then we're naive about how we're interacting with sort of populations that I'm most worried about, which are, poor people, elderly people, women, LGBTQI people, people with disabilities, and the like. And that naivety then transforms us into participants in the, in the violence that people experience.
Yep. Well, you convinced me that's that we need to understand and act on these things. Is there an example that you can give of a encounter that really brought this home to you?
Oh yeah, tons. The hard part's where to start. I had this wonderful experience at Menayawan Health Centre in Sioux Lookout, Ontario, which is a First Nations led, sort of rural hospital in a town of about 5,000 people. Really beautiful hospital, and with a lot of great people working in it. And where do you start? Here's one. So I had to introduce myself to the Council of Chiefs, and so this is, Sioux Lookout, Menayawan serves 29, sort of Anishinaabe and Cree communities, and, which are fly in, fly out in most cases. And although sometimes they get a nice road, and so the chiefs meet, to discuss health issues, sort of, every so often. And so anyway, I go out to introduce myself, and like most people, they never heard of a bioethicist. So, sort of like most people in healthcare don't know what a bioethicist is. And so they're a bit perplexed when someone like me shows up. But anyway, so I introduce myself, and I'm trying to explain, sort of what it is that I do. And at one point I sort of say, one of my worries is about racism in healthcare. Well, the next thing I know, sort of they all start talking about the terrible experiences of their community members. Near-death experiences because investigations aren't being done properly, being treated disrespectfully by doctors, by nurses, by other healthcare staff, administrators, sort of, even more profound structural issues about, sort of grotesque underfunding, sort of First Nations, healthcare facilities in comparison to, sort of equivalent rural facilities, that serve, sort of non-marginalized populations. And it was really, even though I'd sort of spent years, studying the theory of racism, and had a really, really sound conceptual grasp, it felt like my hair was blown off just by and literally it was just one story after another. And after that, I was like, okay, I think we're on the same page, or at least I hope we're on the same page, sort of like, but so that was one example, but there were tons, this stuff happened all the time.
Yep. So I guess the people being exposed, first of all, we asked the question, and we're willing to listen to the answer. I'm not sure that everybody gets, does that or gets that opportunity. How can we create opportunities where for doctors in training and students, etc., that they be able to have a similar sort of experience and have their heads blown off?
Yeah. Oh, it's rich. I like, the heads blown off. This is a good experience. It's a very powerful, beautiful experience, actually, even though painful, like it hurts. There's no question, to sort of just have, this curtain sort of ripped away from you. So obviously, and that's even for someone who has a background in the field. I think you have to locate people in the communities, and you have to create the conditions so that they can make friends. So you develop relationships, you build trust, you hang with them. If they invite you to ceremony, you go to it. You just let whatever you have to let whatever your beliefs are go, all of them, for the purposes of participation, right?
Yep.
Because we carry sort of a huge amount of cultural loading, so much of which is good, but in context, even the really good stuff can be a barrier. But so for the first one is, sort of for doctors or med students or other healthcare workers, just immersion, sort of hanging with people and hearing their stories. I mean, I know, Matthew, that you love and take very, very seriously narrative ethics and the importance of stories. I think people have to be exposed to the stories.
Yep.
But I mean, there's a problem, sort of there's a amount that other people can do, but I think the hardest element of it is people have to let go of their prejudices, and they have to let go of their fear, sort of the encounter, because if they can't do that, then when they're in the environment, they're not going to get anything from it. They may react hostilely, and it's sort of then, I've seen that happen with some healthcare workers too. Even though they're immersed in the environment, they do this, and they back off, and they get defensive, and they get afraid. They get afraid, about, these horrible thoughts about how, as a healthcare worker, I actually might be maligned in context and the like. And so, we can create the exposure, but, the courage and the humility bit, sort of that the individual has to do that themselves, I think. I don't think we can sort of say, look, you need to do this, but we can't do it. Sort of
but I guess the challenge is for us, can we sort of till the soil so that these seeds can grow? And what does tilling the soil look like? Is there something we can teach people that helps them hit these encounters with their prejudices challenged?
Yeah. I think there's a ton of really great things. I mean, I couldn't have done this if other people hadn't taught me some really great stuff. I didn't do this on my own, my own experiences. And I don't want to make any great claims about my own virtue or success here, by the way. I want to be clear about that. Sort of, I think I had some success, but and it's a basic cultural safety principle. The only people who are allowed to say it are them.
Yeah.
And so, I'm on dangerous ground, just, even in sort of, making a claim about insight, in the area. But anyway, I hope I'm justified in doing so. But yeah, I think there's a ton of things that we can do. I think, teaching virtue ethics properly, is a start, because, you sort of teach people about, the fragility of our knowledge, and you teach people about the necessity of humility, in particular as a epistemic virtue for healthcare workers. And that humility is also about what we know, because we get this amazing, wonderful science education, but we don't understand that if we're not humble about it, that becomes epistemic racism. That becomes things like, a denial that, say, the Anishinaabe sweat lodge is a healing function. That it's just as much a function of the healing of people as is chemotherapy, or any kind of standard mainstream, biomedical technique. And again, the point's not to denigrate, sort of scientific knowledge, because, sort of the people I've met all very, very happy with it. It's to sort of be humble about how far that scientific knowledge actually takes us, and when we think about sort of the knowledges of other cultures. And so humility, so teaching virtue, but also teaching people about power, and about how power works to enable certain groups and to disable other groups is really, really important as well. Because if they can understand that, then we can take them to the next step of combining the virtue tradition, and in particular the idea of sort of epistemic humility, with their hopefully their ability to see how they, or me, because I should be doing it in the first person, to be honest, to see how I, am situated within these very, very complex distributional power networks that, especially for someone like me, really funnel benefit my way, and away from others. And if I can really get that into my head, then, and if I can get that reflexive move of humility along with it, then I think that opens up, these amazing possibilities. And I don't think this is a mysterious thing. I actually know a reasonable number of people who, in my judgment, for whatever that's worth, do a good job, of doing this. And, sort of the evidence I have is how people, sort of say Gamilaroi people here, or Komameri people here, or Anishinaabe or Cree, among the people that I used to work with, how they're received. Because this isn't supernatural, crazy, spooky stuff. It's social relations and early functioning. Is trust happening? Are people laughing together? Are they sharing stuff? Are they listening to each other? It's stuff you can see happening. So it's doable. But, it does require a lot of painful and hard work on my part, and on the part of everybody who wants to do this, about the way in which, sort of my own identity formation damages my ability to work and support others. Does that make any sense?
Yeah, no, it makes a lot of sense. I was really impressed yesterday. I ran a teaching session, and there was some video of an interaction between a junior doctor and a supervisor, and the cohort of clinicians was really alive to the interpretation and the identification of the power relationships and
Awesome.
how that impacted. And I think that didn't happen before. So I think we're definitely making progress in people understanding that.
Good.
And key ingredient. Right. Well, that gives us a lot. So one of the things that troubles me is that very often when we're talking about this sort of understanding of culture and context, environment, social determinants, it's always talking about understanding. You understand this, you understand that. And sometimes, you've spoken about ways that you can have a powerful understanding, how it can change your view of things. But I'm interested in what you actually do differently as a practitioner as a result of that. So let's say you've had this transformative moment, you really understand, you get it now. What are you going to do differently?
Yeah. Well, can I just start by giving you an example of what happens when you don't do this?
Yep.
And so, while I was, the area that I worked in has suicide waves of very, very, very young people, 10 to 12-year-old, 13-year-old kids. And they happen about, it's just mind blowing, and so the ecological determinants, and the colonial violence, and the way in which continues to shape the communities is just awful. Well, anyway, during one of these, I was part of a health ethics group. And during one of these waves, one of the people at that group said, we've got to do something, and they sort of said, well, what can we do? We could get a grant, and we could do some research into suicide. And I nearly lost my temper. I don't lose my temper very much, but I was just so furious at the naivety and the idiocy of this. Because if you look at what's actually happening in that suggestion, and if you actually track the line of benefit, where does it go? All right, so we apply for a grant, and let's assume we win it, on a topic like that. The money flows to us, right?
Yep.
The prestige flows to us.
Yep.
The prestige flows to the university, which funds us.
Yep.
The prestige flows to the Canadian Granting Agency, which funds the money. All of the knowledge is already there in multiple coronial inquiries, in a fabulous community inquiry from 2016 that the Mushkegowuk Tribal Council had done into sort of the suicide emergency, in their own communities. That wasn't part of the communities that I worked with. They were on the eastern side of Northern Ontario. And but they did this amazing thing, the People's Inquiry. It's the best thing I've ever seen. And they just did it on their own. But so what happens is people think about doing and they want to do, and they don't get that doing presupposes their own power, right? And so they want to act, and it's like, this is just raw naivety. Because if that had happened, they could have won the grant. There wouldn't have been a single ounce of benefit that would have gone to a single person in any of the communities in Northern Ontario. Nothing.
Yep.
They would have reinforced, it would have been methodologically fine, but all it would have done is reinforced knowledge that was already out there.
Yep.
For no benefit at all. So the question of doing is a really profound one about which most of us, I think, are naive. The first thing, and this can take me back to your question a bit, the first thing is transformative self-understanding. Because what happens then is you start thinking, okay, the question is interest and the question is benefit. What that means is the first decision I have to make is I have to give up my own power. In other words, it's not acting, because the acting reinforces my power. Power has to be given over. That's the act. And that's the act that will make a difference. Very, very profoundly. And of course, there's great, sort of research work, participatory action research note, which tries to do this, and it does all kinds of cool things. It's among other things, it says, well, first of all, the community has to come up with the research plans. It has to have final decision making authority over those research plans. If it decides after you spend 3 or 4 years doing the work for them that they want the thing shelved and never to see the light of earth, then as a researcher, you have to be willing to let it go.
Yep.
Right, because they decide, they're the only ones who know if it's going to benefit them, right? Whether it's cancer research or anything else. So the community has to have the power. The power has to be yielded, to the communities, so that they decide what the knowledge is, which is desirable, not me. They decide, sort of what's going to be beneficial, not me, since I don't have a chance of knowing what a given community actually needs.
Yep.
Right.
So if we take it back to individual patient encounter, what does the giving the power away look like there?
Oh yeah, it's cool. There's lots of good stuff, and it's actually a lot more practical than people realize. It will include anything from sort of co-design of the architectural spaces of the healthcare units. That's what Menno Youwen's really great for. They hired a First Nations architect, and the whole thing is built on the Anishinaabe medicine wheel. And so all of the units are sort of appropriately culturally located from east, which is youth. So you know where the birthing unit is, to north, which is age. Which no surprise, guess where the palliative care unit is, right? And so sort of it's really about the sharing or the yielding of a power is really about making sure that the values of the community is that your healthcare unit is supporting are built according that. And so this is just one thing, but it's built according to the values of the community. And that's very, very profound because the people feel a lot safer.
Yep.
And it was one thing which was really nice. The hospital wasn't perfect, of course. It had all kinds of problems with it. But one thing that was really nice in the patient surveys is they felt comfortable. They felt like it was an Anishinaabe hospital.
Yep.
And it didn't just serve Anishinaabe people, but it was 85% of the patient population was. And so the safety, right? You want a hospital to be a safe place. A very, very mainstream Australian or Canadian hospital is frightening enough to all of us, but it's even more frightening if you're marginalized, in some way. And so, sort of someone like me or some mainstream architect, we can't design that hospital because how would we know?
Yep.
Right. So notice that's a giving over of power, right? It's letting someone else shape the design, but it's also co-design because you still need a cancer unit.
Yep.
And it still has to be able to treat cancer, and so you still need the key elements of a hospital, but we yield our right unilaterally to determine the shape of the care. We allow other epistemic norms and other cultural norms to play a significant role, in every aspect of the hospital.
Yeah. This connects really closely, I think, to some key concepts, the particularly person-centered care, which is really about giving away the power to the patient. And so for me as an oncologist, not holding on to that power. And also it's about student-centered learning. So as educators, so there seems to me a common theme in amongst all those things with the bigger picture aspects that you've been talking about, that reinforces the need for us acknowledging the power and being able to give it away. One of the things that you talked about in terms of the sovereignty sort of stuff is about allowing people to own stuff and own process, own results. And that sort of goes a bit to the point of the giving away the power and becoming an ally rather than the leader. What does allyship mean to you, and how do we implement that in this space?
Yeah, the first aspect of it is getting out of the way. And so again, it's this idea of ceding power is sort of actually the fundamental element of it. But of course, as a privileged individual, there's a sense in which you can't. In other words, there's nothing that I could do that would stop myself from being privileged, because this is a social distributional problem, that's about how whole, large societies are sort of allocating sort of prestige and things like that. And so, one of the key things is you're trying to create space so that other people can exercise decisional authority that's currently denied to them. How do you do that? Well, actually, the main role of the ally is to educate other privileged people to become allies. In other words, to educate others to share power. Or to give up our right unilaterally to act. And so that, really what I'm trying to do here with our med students is teach them that, actually, sort of, and if I can get any of them to learn that, it's always difficult to tell. I know some do, but it's hard to find out how much. But if I can get them to do that, then I think that their capacity to provide higher quality healthcare in support of, the relevant populations will be improved. But yeah, sort of allyship actually is about changing ourselves. So it goes back to that issue of transformative understanding. You know, and sometimes people think about this as a narcissistic thing, you know, sort of navel gazing or looking in mirrors. It's not, right? It's about how am I hurting other people, and how do I change my behavior so that I do less of it and ideally none of it.
Yeah. So being an ally for you is about being an advocate and a activist. Is that a fair summary?
Totally, absolutely. You got to be an activist, and it's also about risk taking. You know, because, you know, the ugly backstory of all of this is that privilege depends upon sort of racism and misogyny and all of these different things. And that only works because groups impose an internal discipline on each other and punish people who break ranks. You know, and so your ally actually has to be willing to sort of take risks, you know, sort of to take a public pummeling of some kind. You know, sort of to challenge the norms, you know, which are sort of keeping these awful systems in place. And so that, you know, sort of teaching that bit of it's hard.
Well, that's very timely because we're recording this interview on the day that Sinead O'Connor died. And one of the remarkable things about Sinead O'Connor was that she was brave. She was an activist, and she got pummeled for it. But I think the willingness to take a risk, to put yourself out there in order to make things better for other people is really one of the things I admired about her. Well, we've covered a lot of ground in a short amount of time. I really love a good philosophical discussion. You've certainly made me think about the priority that understanding violence and power relationships have to us being able to transform the way we see the health system, the way we see society, and therefore the way that we treat patients, and that giving away power is central to that transformation. So thank you very much for your time. And I'd encourage anyone that's interested to look at some of the other conversations we've got on this channel. Thank you, Richard.
Thank you, Matthew. Appreciate it.